Today, I will be discussing to you the pelvic structures that are common to both male and female. Pelvic structures vary differently between the male and the female, but certain portions of the gastrointestinal tract and the urinary system are relatively the same for both men and women. It is my hope that at the end of this lecture, you will be able to identify the common structures between male and female, be able to describe the anatomical structure and its relation in the pelvis, likewise, be able to discuss common clinical conditions that may affect these structures. As a review, the pelvic cavity, or the cavity of the true pelvis, is the area between the pelvic inlet and the pelvic outlet. The pelvic cavity is subdivided into two areas by the pelvic diaphragm into the main pelvic cavity and the perineum. The diagram on the right shows you the subdivision of the pelvic cavity into the true pelvic cavity and the perineum via your pelvic diaphragm. In order for us to fully understand the pelvis, we should be familiar with terminologies and anatomical markers that we use. One is the linea terminalis. The linea terminalis separate the true and false pelvis. The contents of your false pelvis are mostly your intra-abdominal organs, like the small intestines and the colon, whereas your false pelvis is bounded anteriorly by the inner portion of the abdominal wall, posteriorly by the lumbar vertebra, and laterally by the iliac fossa. The true pelvis is bounded anteriorly by the pubic bone, posteriorly the anterior surface of the sacrum, and laterally the inner surface of the ischial spine bone and the sacrosciatic notches and ligaments. The upper border is the promontory and the alley of the sacrum, the linea terminalis, and the upper margins of the pubic bone, whereas the lower border is the pelvic outlet. So, what are now the pelvic structures that are common to both male and females? These are the sigmoid colon, the rectum, the anal canal, if you notice, these are the terminal portions of your gastrointestinal tract. And of course, you have the urinary bladder. Let's go now to the sigmoid colon. Now, the sigmoid colon takes its name because of its shape. The sigmoid colon begins at the level of the pelvic brim and has an S-shaped appearance going up to the level of the third sacral vertebra. And it now becomes continuous with your rectum. The average length is from 10 to 15 inches or 25 to 38 centimeters. There are times wherein It can be longer and more tortuous, reaching to about more than 90 centimeters in length. This is now a condition we call as a redundant sigmoid. Your sigmoid is attached by your mesocolon, and this mesocolon attaches the sigmoid to the posterior pelvic wall. The sigmoid is closely related to the urinary bladder in men. In women, the uterus, particularly the posterior surface and the upper part of the vagina, is closely associated. Posteriorly, both are related to the rectum and sacrum. The blood supply of your sigmoid comes from one of the branches of the inferior mesenteric artery, the sigmoid artery branches. These are several branches that you see in the diagram on the right. The two remaining branches of your inferior mesenteric artery, the left colic artery together with part of your sigmoid artery will supply the descending colon, whereas the superior rectal artery branch of the inferior mesenteric artery will supply the upper rectum. Venous drainage is via the accompanying sigmoid veins that will ultimately drain into the inferior mesenteric artery. Lymph drainage will be along the course of your sigmoid arteries and veins. Now, what about the nerve supply? Nerve supply will be coming from your sympathetic and parasympathetic nerves, and the origin of this would be from the inferior hypogastric plexuses that supply the sigmoid colon. Now, there are several clinical conditions that can affect the sigmoid colon. The sigmoid colon is a common site for cancer of the colon. On the left, you see a normal sigmoid colon during colonoscopy. Colonoscopy is a procedure wherein you can directly visualize the colon by inserting an instrument with a camera in the anal opening that goes all the way to the area of the cecum. You can readily appreciate a smooth mucosa with the presence of your hostra. Now on the right, a tumor is seen obstructing the lumen of the colon. This is your sigmoid colon cancer. As a form of treatment, surgical resection of the colon is needed to relieve the symptoms and possibly effect cure to these patients. Next is, I mentioned a redundant sigmoid earlier. A redundant sigmoid causes extreme mobility and rotation of the sigmoid, and usually it rotates to its own mesentery. The rotation is in a counterclockwise fashion and is known as volvulus, sigmoid volvulus. It is characterized radiographically, as you see on the right side, as the bent inner tube sign or the coffee bean sign, or the kidney bean sign pertaining to its appearance. Patients usually will complain of severe abdominal pain, lower abdominal pain, accompanied by abdominal distension. As a form of treatment, decompression of the bowel followed by surgery is the management of choice for volvulus. Next are the presence of outpouchings or thinning out of the colon. And this is what we call colonic diverticulus. Colonic diverticulus are very, very common in the sigmoid colon. As I mentioned, diverticulus are thinning or outpouchings of the mucous membrane. On the right, you see the segment of colon with several diverticulus or rounded circular thinnings of the mucosa. It is commonly seen as the effect of high pressure on the colonic walls and can cause abdominal pain, bleeding, or even perforation. Medical management is usually initiated for these types of patients. However, ultimately, if this will fail, then there is a room for surgical resection or management for these types of patients. Next is your rectum. The rectum begins as a continuation of the sigmoid at the level of the third sacral vertebra, and it ends at the tip of the coccyx. On the average, it is about 13 to 15 centimeters long. Intraluminal curves, or more commonly called valves of Houston, divide the rectum into three parts. The upper rectum is approximately seen between the 12 to 15 centimeters from the anal verge. Mid-rectum is at the level of the 6 to the 10 centimeters from the anal verge, whereas the lower rectum is below the 6 centimeter mark from the anal verge. The peritoneum covers the anterior and lateral surfaces of the first third of the rectum and only the anterior surface of the middle third, leaving the lower third without any peritoneal covering. There is a slight difference in the anatomic relations in the male and the female. Looking at this table, you see the differences. Due to the presence of the uterus and the female reproductive organs and the male reproductive organs, the anterior relations are varied. However, the posterior structures remain the same. There are three main sources of blood supply to the rectum. These are the inferior mesenteric artery, internal iliac, and internal pudendal artery, and its respective branches. Venous drainage is via the accompanying veins. The lymph vessels of the upper rectum drain into the pararectal nodes and then into the inferior mesenteric nodes. Lymph from the lower part of the rectum follow the middle rectal artery to the internal iliac nodes. Nerve supply come from the inferior hypogastric plexus. So again, the blood supply will be coming from branches of three main arteries: your inferior mesenteric artery, your internal iliac artery, and your internal pudendal artery. And the specific branches are from the superior rectal artery, the middle rectal artery, and the inferior rectal artery. Venous drainage is via the accompanying veins of these arteries. Next is your anal canal. The anal canal is the final segment of the gastrointestinal tract. Normally, it is collapsed except during the process of defecation. The internal anal sphincter surrounds the upper two-thirds of the anal canal and is involuntary, whereas the external anal sphincter surrounds the lower two-thirds of the anal canal and is voluntary. At the junction of the rectum and the anal canal, there is a muscular ring that is palpable during digital rectal examination. This is called your anorectal ring. It is formed by the fusion of the internal anal sphincter, the external anal sphincter, and your puborectalis muscle. Pelvic structures that are closely related to the anal canal are basically the same, except for the difference of the reproductive organs in the male and the female. Anteriorly, the vagina of the female is closely related to the anal canal, whereas the urethra and the bulb of the penis are associated for the males. Posteriorly, both will be closely associated with your anococcygeal ligament, the coccyx, and the sacrum, whereas laterally, it is associated with your ischianal fossa. Now again, clinical conditions may affect the rectum and the anal canal. And these are the common conditions that we see affecting these two structures. One is your rectal prolapse. Rectal prolapse is a relatively common condition. Incomplete rectal prolapse, the one that you see in figure A, the whole thickness of the rectal wall protrudes through the anus. For partial prolapse, figure B, the rectal mucous membrane and the submucous coat protrude for a short distance outside the anus. On the right is an actual patient with rectal prolapse. As you can see, this is a uh, complete rectal prolapse with the typical and very characteristic honeycomb appearance of the prolapse. Hemorrhoids are again commonly seen in individuals both male and female. On the right, you see a diagram showing you the different stages of the formation of your hemorrhoids. Your hemorrhoidal venous plexuses are normally seen. in the anal canal. However, because of either uh, obstruction or an abnormal flow in the blood in your venous plexuses, you see them as palpable masses in the anal canal. And they are subdivided according to the degree of obstruction or protrusion of mass in the anal canal. The first degree hemorrhoids are hemorrhoidal venous plexuses that swell up and bleed while straining during defecation. You might not experience any uh, mass in the perianal area, only pain and bleeding. Second degree hemorrhoids, your hemorrhoidal venous plexuses prolapse with straining, meaning you will see a visible mass going out of the anal opening, but is reduced spontaneously, meaning the mass goes out and subsequently goes in, no, without doing anything. Third degree hemorrhoids are hemorrhoids that remain outside of the anal canal unless manually replaced, meaning you have to push the mass so that it will go inside the anal canal. And lastly, a fourth degree hemorrhoids are hemorrhoids that cannot be reduced or cannot be pushed back inside the anal opening. Primary management is medical for grade 1 to 2 hemorrhoids, meaning no surgery required. However, if it goes to your grade 3 to 4 hemorrhoids, then surgical intervention is now needed to correct this problem. Rectal cancers or rectal carcinomas are also very common. It is one of the common causes of bowel obstructions in patients, especially in the elderly. On the right, you see again a colonoscopic picture showing you the rectal mass and almost completely obstructing the lumen of the rectum. Spread is local, as you can see in the CT scan on the right, affecting the other pelvic structures. Management is primarily resection of the involved segment of the rectum. We are now on our last organ in the common structures in the pelvis for male and females. And this is the urinary bladder. The urinary bladder is a hollow muscular organ with the main function of storing urine. This is seen immediately behind the pubic bones and maximum capacity if it's filled is around 500 ml. Note that there are also slight differences between the male and the female bladder. The male bladder, as it rests in the pelvic cavity, the base is closely associated with the seminal vesicle and the vas deferens, and it is separated from the rectum via your Denon-Villiers fascia. The superior surface of the bladder is closely associated with the sigmoid colon and parts of the ileum, whereas the inferolateral surface is associated with the space of retius or your retropubic space. The urinary bladder forms angle in its normal location in the pelvic cavity. And within the apex, this is connected in your median umbilical ligament or your urachus, whereas the neck is associated in the internal urethral orifice. Your superolateral angles are seen closely associated with the ureter. In females, the base of the urinary bladder is closely associated with the cervix and the upper vagina. Likewise, it is also related to the ureter. The superior surface is closely associated with the majority of the ureter, and the inferolateral surface is again associated with the space of retius, pretty much the same as that of the male urinary bladder. The urinary bladder is fixed in the pelvic cavity by the presence of your true ligaments. So this secures its position in the pelvic cavity. True ligaments holding the bladder in place are your pubovesical and your rectovesical ligaments. The median pubovesical and lateral pubovesical ligaments are seen between the pubis and the neck of the bladder, whereas the rectovesical ligament is seen from the bladder to the sides of the rectum and your sacrum. Your false ligaments that are actually seen also on the sides of your urinary bladder are from the medial umbilical ligament, which is the obliterated umbilical artery, and the median umbilical ligament coming from your obliterated urachus. Arterial supply for the bladder is via your superior vesical branch of the internal iliac artery. In males, this is supplemented by the inferior vesical artery, and in the females, by the vaginal arteries. In both sexes, the obturator and inferior gluteal arteries may also contribute small branches. Venous drainage is achieved by the vesical venous plexus, which empties into the internal iliac veins. Your lymph drainage is via the internal and external iliac chain of nodes. Nerve innervation to the bladder is via the hypogastric plexus, which gives sympathetic innervation, whereas the second, third, and fourth sacral nerves give parasympathetic innervation. Parasympathetic innervation causes contraction of the detrusor muscles, thereby emptying the bladder. And these nerve innervations are responsible for actually also initiating the micturition reflex. Thank you very much for listening. Coverage of my lecture is from your official textbook, which is Snell Clinical Anatomy by Region, pages 1060 to 1100. I encourage you to read on your textbook to supplement the highlights of my lecture. The actual correlation and discussion of the anatomical structure seen in the pelvis will also be given to you in your laboratory session so that your lecture and your laboratory sessions will reinforce your knowledge of the topic. Thank you very much. Okay, so are there any questions?